I was asked to speak on the status of bone in the parathyroid disorders, and in the next 30 minutes, I will try to give you an up-to-date view of bone disease, both in hyperparathyroidism and in hypoparathyroidism. And here are my disclosures. Let us start with the disorder associated with too much parathyroid hormone. We all know that primary hyperparathyroidism is a very common endocrine disorder characterized by incompletely regulated chronic excessive secretion of parathyroid hormone from one or more of the four parathyroid glands. Classically, hyperparathyroidism is associated with hypercalcemia and elevated levels of parathyroid hormone. Some patients don't have frankly elevated levels of parathyroid hormone, but they are inappropriate for the presence of hypercalcemia. We won't have time today to talk about another variant that is normocalcemic primary hyperparathyroidism. This disorder can be characterized in three generational phenotypes. And in most of the world before 1970, this was a disease of bone, stones, and groans. And many of you know the famous photograph of the captain on the left, Charles Martel. You can see what happened to him after only several years of uncontrolled primary hyperparathyroidism. On the right is a patient I took care of many years ago, and you can see the classic radiographic features with the salt and pepper degranulation of the skull, the distal clavicle you cannot see radiographically, the subperiosteal bone resorption of the phalanges, and the pelvis of this woman whose bones are literally riddled with osteitis fibrosis cystica. Now, I know in India, it's still very much that kind of disease, and we're going to speak about it. But for most of the world, after 1970, hyperparathyroidism became characterized a bit differently. That is, a disorder that was characterized primarily by biochemical and densitometric signatures. This is a table from our work, but it has been duplicated by many studies showing mild hypercalcemia, a parathyroid hormone level that is about 1.5 to 2 times the upper limits of normal. And vitamin D metabolism shows a level of 25 hydroxyvitamin D that typically is in the low range or frankly deficient, with a level of the active metabolite of vitamin D in the upper range of normal. We were one of the first groups to identify an interesting skeletal pattern of involvement using dual energy X-ray absorptiometry. This again comes from our work indicating that there seems to be, at least from DEXA, a proclivity of parathyroid hormone to affect cortical bone. You can see on the right, the distal third radius region is much reduced compared to the lumbar spine as well as the femoral neck. And this cortical predominance seemed to be different from what we typically see in postmenopausal women with osteoporosis, who have the reverse in the early phases with more involvement of trabecular bone, and only later do they have involvement of cortical bone. Now, this change in phenotype, we believe, is due to the introduction and widespread use of biochemical screening tests that typically include a serum calcium determination. And in countries where calcium is not a routine screening test, hyperparathyroidism tended to present still as a more symptomatic disease. And this global map indicates in blue those countries about which I speak, namely where hyperparathyroidism was and still is commonly seen. And you can see on this map, India is prominently highlighted as one of the countries in which symptomatic disease seems to still be common. Also noteworthy is the point that in countries where serum calcium becomes a routine screening test, hyperparathyroidism tends to change to a more asymptomatic disorder. This is an experience from Brazil, from our colleague Francisco Bandeira, showing that in Brazil, as calcium became more widely used, in the white lines, you can see the average serum calcium falls, and in the blue bars, you can see that the percentage of individuals with asymptomatic disease increases. Now, that was the case in Brazil. Similarly, in China, working with my colleagues in China, we showed many years ago that it was a symptomatic disease. 90 to 95% of individuals had that classical phenotype. But more recently in Shanghai, you can see in the blue part of this graph, the incidence of asymptomatic hyperparathyroidism has increased. Now, the situation in India is also very noteworthy, and Dr. Bagdada and Dan Rao and all of your colleagues have nicely contributed to this point, that even in India, again, it depends on the part of India. Ambrish Mittal has shown that in the northern regions of India, there is more asymptomatic disease. But here in this experience that was just published, you can see in the light blue bars, the incidence of symptomatic disease is dropping, and in the darker bars on the bottom, the incidence of asymptomatic disease is increasing. This may also relate to levels of vitamin D, which chronically in India have been extremely low, another point that we will touch on shortly. Now, this presentation is going to focus only on skeletal assessment, and based upon the bone density I showed you earlier, one might expect that in terms of fracture risk in hyperparathyroidism, the vertebral sites would not necessarily be more than others because bone density seems to be well maintained, while at non-vertebral sites, as shown by the distal third radius, one might expect an increase in non-vertebral fractures. However, the clinical data really do not support that expectation. This was work from Sandeep Khosla at the Mayo Clinic, indicating that if you look at observed fractures over expected fractures at the vertebral site, you see actually a higher incidence of fractures, similar to the higher incidence of fractures at that distal forearm site. In fact, all fractures, based on that experience at the Mayo Clinic, were increased in primary hyperparathyroidism. Now, this has been actually looked at in a meta-analysis by Lars Renmark in Denmark, looking at all the studies related to fracture risk in primary hyperparathyroidism. And you can see in this table, any fracture, the odds ratio in hyperparathyroidism is twice the average, with a confidence interval that clearly indicates a significant increase of fracture at all sites. But more specifically, one looks at forearm site or the vertebral site, you also are seeing a significant risk of fracture. Again, this supports the notion that in primary hyperparathyroidism, fracture risk has increased overall. Now, how do we explain this? By virtue of the anomalous pattern I showed you earlier in terms of the DEXA results. And I think this can be explained by our opportunity to exploit some of the technological advances of bone imaging to identify the extent to which the skeleton is involved in hyperparathyroidism, even in those who don't present with overt issues. We have taken advantage of high-resolution peripheral quantitative computed tomography to look into this, because this technology allows us to look at skeletal microstructure non-invasively at both cortical and trabecular sites. And this is just a depiction of some of our work. On the left, a matched control of the distal forearm, and you can see on the right the beginnings of what I'm going to show. That is, there is also, there's evident cortical thinning, but also in this depiction, you can see the trabecular compartment is also abnormal. Hansen from Denmark first showed that if you look at it by extreme CT at a number of cortical and trabecular parameters, I'm going to now show you those trabecular parameters, particularly at the radius, but also at the tibia, there is involvement. So by extreme CT, there seems to be both cortical and trabecular involvement. And our work supported that work from Hansen. And this is from our work looking at both the distal radius and the distal tibia. Again, you see a number of cortical and trabecular indices being measured. That red line in the middle of this graph is normality, and to the left or to the right, depending upon the index, there is an abnormal trabecular and cortical bone. So again, by extreme CT, there seems to be involvement of both trabecular and cortical indices. Now, we do have a problem because if DEXA is not giving us the information we are looking for, and if HRPQCT is, but is not a widely available tool, it would be nice to be able to access another imaging modality that does allow us to look at this from a clinical point of view. And that is, that technology is the trabecular bone score. I know all of you are very familiar with the trabecular bone score. It's an adaptation of that lumbar spine image by DEXA. And using TBS, we've been able to actually show that the worst classification, namely the degraded classification, is seen in about 36 of our patients. If you again go back to the lumbar spine DEXA, only about 14% of our population had frank reductions in bone density. So I think we could then conclude that this rather easily available technology, TBS, might help us in terms of identifying the point that in hyperparathyroidism, both cortical and trabecular compartments are involved. And this helps to account for the global increase in fracture risk in primary hyperparathyroidism. Based upon this, we and many of our colleagues around the world, based upon the most recent international workshop that's been published on the management of asymptomatic primary hyperparathyroidism, we have recommended the evaluation of skeleton, not just by DEXA, but by some other imaging modalities such as vertebral fracture assessment, trabecular bone score, or straight vertebral x-rays. I alluded to vitamin D, and I think this is really an important point. And you know this very well because India is where we have learned so much about how important vitamin D deficiency is in the population. Stanbury from UK made this statement many decades ago, that the clinical manifestations of primary hyperparathyroidism may be more severe in the presence of vitamin D deficiency. And Dan Rao has contributed enormously to our understanding of that point. In our work with our colleagues in China, again, I alluded to the point in that older series that 95% of the Beijing population with hyperparathyroidism had symptomatic disease, compared to our New York population, in which only 20% of our population was symptomatic. And the telling point of these two experiences is shown at the bottom of this table. That is, the 25-hydroxyvitamin D in the Chinese experience was markedly low at 8 nanograms per ml, whereas in our experience, the 25-hydroxyvitamin D was substantially higher at 21 nanograms per ml. And actually, if you take that 20 nanograms per ml and look at our population below or above Those who have levels below 20 nanograms per ml had parathyroid hormone levels that were markedly higher. You can see 250 picograms per ml versus the group with 25 hydroxy vitamin D levels greater than 20 nanograms per ml, in which the levels were parathyroid hormone were much lower. Now, this again alludes to the work of the Indian experience, and I've noted this series before, but it was very interesting that the 25 hydroxy vitamin D level, while lower in the symptomatic group, you can see at 21 nanograms per ml, this was only minimally lower than the asymptomatic group. And noteworthy, and again, Dan and Dr. Bagdata and a lot of you have contributed to our understanding. Looking at parathyroid gland weight was markedly greater, but I don't know if the vitamin D issue can be clearly related to the greater symptomatic disease, at least based upon this experience. Nevertheless, we are recommending levels of 25 hydroxy vitamin D greater than 20. Well, that's the universal recommendation, but most of most of us are recommending levels in hyperparathyroidism greater than 30. And although we're not speaking about normocalcemic primary hyperparathyroidism, many of us would like the 25 hydroxy vitamin D level to be greater than 40. Now, just briefly, after successful parathyroid surgery, bone density improves quickly and markedly. First at the lumbar spine, then at the hip region, and then ultimately also at the distal third radius. This is without specific anti-resorptive or anabolic therapy. The increases over the 10 to 15 years ranges between 10 and 15% at all sites. And you can see by extreme CT how much improved skeletal microstructure also is after successful parathyroid surgery. Now, in those individuals who don't have surgery, over the first 8 to 10 years of our experience, bone density is remarkably stable. But we were noted and we were interested to note that the next 5 years of our prospective study was associated with reductions of bone density at the femoral neck and more profoundly at the distal third radius, which gives us reason to be cautious about very long-term conservative management of asymptomatic hyperparathyroidism. In our experience, about 40% of our patients over those 15 years developed one or more indications for parathyroid surgery. For pharmacological approaches, I'm focusing again only on bone mineral density, and specifically, I've now bracketed those pharmacological agents or combinations that have been associated with an increase in bone density. They include the bisphosphonates, cinecalcet in association with the bisphosphonates, but not cinecalcet alone, and much more recently, denosumab. And this more recent experience is an interesting one, looking at postmenopausal women with or without primary hyperparathyroidism. In the black, you can see after 2 years, the group with hyperparathyroidism had a much greater improvement in bone density with denosumab than the group in the shaded bar. These were postmenopausal women without hyperparathyroidism who were treated with denosumab. So this is another option with regard to the skeletal features of hyperparathyroidism in those who are not going to have parathyroid surgery. Now let me turn to the other disease, that is the disease associated with too little parathyroid hormone. And of course, this is hypoparathyroidism, characterized by hypocalcemia and low levels or undetectable levels of parathyroid hormone. In that yellow bar, you can see the classic biochemical combination of a low PTH and a low serum calcium. The pathophysiology of hypoparathyroidism involves the target organ, so parathyroid hormone. Without parathyroid hormone, we lose that calcium conserving ability of PTH. We also lose the regulation of phosphorus by PTH. The other point is that without PTH, we have an impairment in the activation of 1,25 dihydroxy vitamin D, leading to reduced calcium absorption. And without parathyroid hormone, we lose that ability of PTH to keep the skeleton dynamic and to provide calcium to the extra skeletal space when needed. And as a result, this pathophysiology leads to hypocalcemia. Again, for this presentation, I'm focusing only on the skeletal abnormalities. The first point to make is that this is a disease of very low bone turnover. The typical remodeling cycle on the right, you can see, is markedly prolonged over 200 days versus on the left, the typical remodeling cycle. Both the formation and the resorption periods are much longer and delayed. In addition, if one looks at the dynamics by histomorphometry and tetracycline labeling, on the right, you basically don't see any tetracycline uptake because bone turnover is so low. Now, we know that bone quality has a number of features. We are going to speak of bone density in a moment, and I'm just going to touch on some of these other aspects of bone quality. I alluded to the low turnover. This slide indicates, again, from our work, markedly reduced osteoid surface, bone formation rate, mineralizing surface, mineral apposition rate, and bone resorption rate. So everything is ratcheted down in hypoparathyroidism. While bone turnover markers may seem, therefore, to be useful, on the right, you can see the shaded bars are the normal range with these bone turnover markers, bone resorption and bone formation markers. But in the black bars, you can see that they're in the low range of normal. But from a clinical point of view, the use of these bone turnover markers, as a result, has not been all that useful. The skeletal dynamics, thus, by bone biopsy, marked reduction in bone turnover, but bone turnover markers in the circulation do not really help us to identify this low turnover state. The structural features of bone in hypoparathyroidism, I alluded to bone density, and quite different from hyperparathyroidism. Bone density is uniformly above average for age at all sites. This is from our work, but in addition, this work has been confirmed by many others. This is the work from Lars Renmark in Denmark. Again, patients have above average bone density at all sites. And over time, and I think you have contributed to this, your colleagues, there is a further increase in bone density over time. Looking at trabecular architecture, cancellous bone volume is increased, trabecular width is increased, trabecular number is increased, and trabecular separation is reduced. Again, this comes from our work. As a result, looking at micro-CT images of hypoparathyroid bone, this is really a remarkable depiction. It really makes an important point. On the right, you see a block of bone that looks like a block of concrete. And I like to think of this as the corticalization of trabecular bone. This is the trabecular compartment. If I were to show you a similar micro-CT image of hyperparathyroidism, you would have seen the opposite, namely the trabecularization of cortical bone. So in summary, with regard to bone properties, cancellous bone volume is increased, cortical thickness may be increased or decreased. It's a little controversial about that. Not controversial is the remodeling rate, which is reduced, as well as the mineralization density and collagen maturity all increased. As a result, one might have certain expectations of fracture risk in hypoparathyroidism. If one looks at bone density, that is above average, you would say that fracture incidence should be reduced. On the other hand, since this is a markedly low bone turnover state and bone becomes hypermature and therefore more brittle, that fracture incidence would be increased. And then the last point is that we don't know, because the balance between stiffness and toughness is hard to predict. On the one hand, it might resist biochemical stress up to a point, but then when those forces are exceeded, you could have extremely high risk of fracture. So what are the data? Yeah, this is the large experience from Lars Renmark in Denmark, showing two groups of individuals with post-surgical and non-surgical hypoparathyroidism. There was no difference in overall fracture risk as compared to the control population. He did show, however, that those without surgery, that is the idiopathic hypoparathyroidism, had an increase in upper extremity fractures, which was sort of interesting. Non-surgical subjects showed an increase in morphometric vertebral fractures. This work comes from one of your colleagues, Professor Goswami, and this is an interesting work of individuals with idiopathic hypoparathyroidism. This is a young group of individuals, only 37 years of age on average. You can see the biochemical features there. I was intrigued by the 25 hydroxy vitamin D level. The group with hypopara, of course, have levels that are higher because they're getting vitamin D. But here's the control population in India. You can see the average level. This was just 3 or 4 years ago, this study, still are markedly low at 10 nanograms per ml. This study does confirm the notion that there's an increase in fracture risk. You can see vertebral fractures are increased, as well as are multiple vertebral fractures compared to this control population. Those fractures were not major, they were noteworthy, but they were generally in the grade 1 or grade 2 category. And Dr. Goswami did point out that the use of anti-seizure medications and menopause were risk factors for fracture. This is work from Salvatore Minnesota's group in Italy, in which I collaborated. This is a group of post-surgical hypoparathyroidism. This work was just published. A group older than the group I just reported. Again, clear-cut hypoparathyroidism. And again, you can see higher incidence of vertebral fractures in the hypopara group compared to the control group. And again, the fractures were a mixture of grade 1 and grade 2 by the Janat semi-quantitative experience methodology. Now, this is where we are, kind of, and you could say, well, why don't we know more about fracture risk and hypoparathyroidism? And I think the answer is because it's a rare disease, and we really don't have enough epidemiology to be certain about whether or not fracture risk is increased or decreased in hypoparathyroidism. Coming to therapy, conventional therapy with calcium and active forms of vitamin D sometimes can control the biochemical abnormalities, but it doesn't do anything to reverse the pathophysiology of absent parathyroid hormone. So what are the skeletal effects of recombinant human PTH 1 to 84 in hypoparathyroidism? The first point is that the skeleton wakes up. And you can see by this double label bone biopsy from our group, the labels after 3 months of PTH are markedly more evident, as clearly demonstrating an increase in bone turnover. The structural aspects, I don't have time to go over, but you can see that some of those abnormalities I pointed out earlier are reversed when we use recombinant human PTH 1 to 84. As I mentioned, the dynamics change, the bone formation and bone resorption markers. There's a burst of activity, and then it settles down to levels that are more normal or more comfortably in the normal range. Bone density, interestingly, has increased at the lumbar spine in the yellow, not changed materially at the hip region. And as you would expect, the distal third radius is showing some of those catabolic features of hyperparathyroidism, namely it falls somewhat over time. By more specific imaging using extreme CT, I don't have time to go over all these indices, but in short, they are really going in the direction that you would expect, mainly to correct those microarchitectural abnormalities that have been characterized in hypoparathyroidism. So in summary, the basic characteristics show in hypoparathyroidism markedly abnormal dynamic and structural elements. We have an uncertain relationship of these elements to bone strength and fracture incidence. With regard to treatment using recombinant human PTH, we see improved skeletal dynamics. We see changes in bone density that actually follows what you would expect when we use PTH in euparathyroid subjects. The microstructural elements seem to follow those directions that we would expect and are in general beneficial, but we still don't have information about fracture risk in hypoparathyroidism. So let me just end my talk. It came in two parts, and I would just summarize by making a comment, not too philosophical, but what is life with too much or too little parathyroid hormone? Life with too much parathyroid hormone, that is primary hyperparathyroidism, is not good. And life with too little parathyroid hormone, namely hypoparathyroidism, is not good. I think these two diseases illustrate the Goldilocks principle, which is we need just enough PTH, not too much and not too little. So I really appreciate the opportunity to be with you. Here I am in New York, and there are many of you are in the United States as well. Many of you are in India, but we live in a virtual world. But nevertheless, I hope this presentation has been useful to you, and hopefully we will have opportunity for discussion at this time. Thank you very much for your attention.